missing out? I'm getting an old person. I can't figure out stuff. Okay. All right. Thanks everybody for coming. Hey, Megan. I thought we could go over an interesting case that rolled through the ER this week, and it has to do with ankylosing spondylitis. So I'm a big fan of case-based learning. So this is the case. It's a 70-year-old man who presented to the emergency room with low back pain and spasms. Hartford County has a lot of land, so everybody has a tractor. So he was mowing his tractor, and something happened and he fell off. It wasn't a high-level injury, but immediately afterwards he had terrible pain in his back, and his wife took him to the emergency room. Other than this injury, though, he's been a pretty healthy man, takes care of his house, and no significant medical problems, or just hypothyroidism, I think. So here are the x-rays, Adam.
All right, so AP and lateral of the lumbar spine. Looks like, if you look at, let's see, I think that's L4, superior end plate. Let's see if I can get my
I can point for you here.
Thing.
Right here?
Yeah, there, and then that one.
Yeah.
Up higher.
Yeah.
Right there, that bowing.
Yeah.
So that's a L4, that's a superior end plate fracture, very common insufficiency fracture. As I've been told, I look at x-rays and I can form an opinion about bone mineral density, and we like to do it, but we're told that when they do studies on it, radiologists are notoriously bad about actually being a good judge of bone mineral density from x-rays.
You can't judge bone mineral density on an x-ray.
Because of the
technique, if you're a
Right.
fat person, or if you're a person with a lot of mass, you underpenetrate. If you're a thin person, you overpenetrate. So you can make a person look osteoporotic or osteopetrosis by an x-ray. You think that's a fracture at that level, Adam? Boy, I thought that's
At L4?
I thought that's a vacuum disc phenomenon to me.
No, you'll see. Adam's right.
Yeah.
Adam's always right.
Did you tip him off?
No, I didn't tip him off. Adam's always right. Go ahead, Adam.
But for a vacuum disc, I'd expect to see the black of gas, and there is no gas there.
Input. Wow.
You'll see. There'll be more images. Adam's right.
So then, if you go up, So there, I'm saying that's 3. So now with the L2, L3 disc space, the end plates are very irregular, sclerotic. You don't have a normal disc there. It's anteriorly, it's sort of discontiguous. You can see that it's not across. Again, unfortunately, I can cheat because I know what the topic of today's conversation is, but you can see the anterior at the L3, L4 disc, right there. There is bone bridging between the L3 and the L4 disc. I don't see as well at 4, 5, but I could imagine perhaps that again on the lateral.
You'll see. There'll be more images. These are just the X-ray images. They're very poor images for some reason.
Big person as well.
He was in horrible pain. He could not sit still. This man. So it's a lot to ask for somebody to sit still when they're in horrible pain.
But I'd be concerned of discitis at L2, 3.
Okay, so possible. Let me just say this is 4, 3, 2, 1. So let's call it L1, L2.
1, 2, yeah.
So possible L1, L2 discitis is your diagnosis. You want to comment?
Again, I wouldn't think it was acute. And then now because I know the topic of conversation is on the frontal radiograph, you can see the SI joints. You don't see them. They're fused.
Nope. Okay, you sure of that?
No.
Okay. Okay. What about? So he had back pain and abdominal pain, and they sent him. Basically, if you come through the ER and you're not sure what it is, everybody gets a CAT scan. So.
That's because the radiologists are out there with the
radiologists
holding up the.
Radiologists make us do all sorts of studies. So he got a CAT scan.
So he got a CT, I like to call it, because the A stands for axial, and the only axial CTs we do nowadays are pretty much head CTs.
Okay.
Everything else is helical. So really a better term is CT scan.
Okay, CT scan.
But anyway, so there are the SI joints. You can see that there's no joint space there.
Normally there's a black line.
And especially at the anterior margin, which is sort of the synovial part of the SI
right there,
joint.
that you see that white line that gets pretty continuous.
Solid lamination.
What about these CT scans?
So now the CT scan, again, you look at L4, you can see that superior end plate is bowed, and there's loss of vertebral body height at the L4 vertebral body. And now you go back to our L1, L2 level, and it's not as eroded as it looked on the plain film. Again, this is just one slice out of the whole summation.
I'll show you a couple more.
But there's I mean, you can see now looking at the very top and all the way down that there's an anterior cortex that goes all the way down, except at the L1, L2, and maybe a little bit at the L2, L3 that is ossified. And it actually doesn't quite have it.
How
at
about
4,
here?
5. Yeah,
Is there
4, 5.
Not
It's
here,
trying
huh?
to do it a little bit at 5-1.
Okay, but there is continuous white, which
Yeah.
is consistent with what?
Especially at the for ankylosing spondylitis, ossification along that anterior longitudinal ligament.
Okay, but there's no white here.
Right.
Does that change your diagnosis or no?
No, it's enough, especially higher up at the thoracolumbar junction.
Okay. Do you know of any other disease processes which could look like this?
Well, the disease process that causes ossification along the anterior margin of the vertebral bodies, there's a disease called DISH, which is diffuse idiopathic skeletal hyperostosis. The difference between DISH and AS is that DISH, they're big mount hills. And classically, it's described as 3 contiguous levels of hills, not just flat, but of much more,
A lot more cortical bone in the front, right? Some people describe it as like flowing wax.
Yeah.
Okay.
Yeah, 3 contiguous levels of flowing osteophytes.
But this looks
DISH.
is different, right? It's very
This
thin.
is flat and
Yeah.
thin, which is what the bamboo spine of ankylosing spondylitis.
How about this? Does this look normal to you? The axial cut? Not sure. If you can't tell, you can't tell.
Well enough. Yes, there's some cortical discontinuity on the lateral margin of the pedicle there, but
Not sure.
the graininess of it, I can't say for sure.
How about this image? This image change?
The one on the left doesn't change much, but the one on the right, you've got lucency coming through and then coming back down into the posterior elements there.
Into the pedicle, right?
Yeah, that's lucency. And again, in a patient with AS, they don't dislocate the fracture because they were solid.
So it's one continuous long bone. So what would you be concerned of here?
That he fractured through the disc space, then into the bone at L1, L2, into the posterior elements of L2 across the pedicle.
Okay. And here's your SI joint. Remember, you said it looked fused on the X-ray. What do you think here?
Yeah, anteriorly you can see it's fused. There's that same contiguous line of cortex, and it's the synovial part that's anterior, and that's the part that generally.
Does this look fused here?
Not as much. Can't tell as well.
Does not look fused there, right?
Yeah.
Okay, so this patient was admitted to the ER, and his diagnosis was just back pain, sprain, and it initially was missed, but it commonly is. You know, these injuries are. He did not come in with a diagnosis of ankylosing spondylitis. He never, ever, and he just says back hurt. Very subtle images came through the middle of the night, and he was just admitted, and for days he was being worked up for this back pain. He had a leukocytosis, which and they thought he had a disc space infection. So here's the MRI scan.
So there's the MRI, and again we're at 1-2 is that level there, and there's fluid, which is the bright signal in there. This is a T2 weighted sequence. I think you can see sort of in the spinal canal. You look at the CSF. It's not fat suppressed. You can look at the subcutaneous fat and see that that's bright. So the things that are going to be bright are water and fat. And so in that joint
Here's some
space
water.
there is water, and the end plate is irregular, and it's eroded down into the L2 vertebral body. So I think discitis is feasible. And the issue against it is just down and to the right there, where there you have some low signal or high signal, extending back into the posterior element through the vertebral body, which makes this, more likely to be fracture, I think, because it's out of the disc space, and it's a linear
Right, here's the end plate.
out of the disc space.
Yeah, here's the end plate. So this is the disc. So this process goes under the disc
Yeah.
into the pedicle right
Into
here.
the pedicle.
Yeah. So here's another close-up view of it. So the issue is, Doug, tell everybody what's going on here. Like just ballpark, just to give an idea of the seriousness of this problem.
Well, his spine is basically fused, so when you have a fracture, you have a high lever arm. So a normal person has a little bit of motion at each segment. This guy has no motion
Anywhere.
anywhere.
Yeah.
So when you have this, then all of a sudden you have a long lever arm. Basically, the whole body is going to torque on that area. Number one. Number two, it's highly vascular. Like if you ever operate on these people, the difference between normal tissue and malignant tissue is that malignant tissue has no vascular
Normal tissue.
Tone on it.
Normal.
So when you cut it, it bleeds and bleeds and bleeds. Normal tissue, you have vascular tone. So when you cut it, you get innervation into the arteries, and they clamp down, and it doesn't bleed. It's similar to this. If you go through this and you break this, or if you cut this, it just bleeds everywhere. So when you have a spinal fracture in someone with AS, there's a high proportion of these people get bleeding into the spinal canal, and you can get neural compromise.
Epidural hematoma. So you get epidural hematoma and you get neural compromise. So the whole spine's welded together. It's like a baseball bat. And then it just cracked in the middle. And you can imagine if it's going to move anywhere, it's going to move where the fracture is. So it's horribly painful for these people. And also you can get a neurological injury. Luckily, this guy did not. So what do you think we should do, Doug? Should we just watch it, or more physical therapy, or?
No, he needs to be stabilized. I wasn't terribly impressed with the imaging studies about whether he had much bleeding into his.
I didn't show. Here's a canal right here.
It looks like he's got a zone of injury.
He doesn't.
So,
He couldn't sit still for the study. That's the whole problem.
So maybe it's a one motion artifact.
Yeah, he can't move.
So he basically needs to be. He needs to be stabilized. He needs to be fused. But the question is, how much of a decompression does he need? If any?
Okay, that's a good point actually. And so the issue, he's got a fracture. He's got ankylosing spondylitis, and this is an unstable injury because it goes through the whole spine. So it's not like a compression fracture or any other type of fracture. It's a very unstable injury because the whole spine is also fused. So it's a very bad situation, and it's at the level of the spinal cord, so he could get a neurological injury. So these things are best treated with surgery. And I did not do a decompression, and the reason is it's not an emergency. The surgery is not an emergency, but it's better to get it done soon, the next day, and that's what we did. And as far as instrumenting it, I felt I needed 4 points above and 4 points below, just like like a femur fracture. It's the strongest way to get good stable fixation. And then the question is, do you decompress? I mean, decompressing does come with some. Everything in life is a risk-benefit ratio. So I thought initially I put in the consent decompression, and I thought about it. During the operation, it's exactly what you said. He was extremely vascular. But not all ankylosing spondylitis cases are like that. So if the ankylosing spondylitis is active, it's extremely vascular, just like you said, because it's an inflammatory condition. But if it's old and chronic, there's no vasculature whatsoever. And when you open it up, it's like a femur. It's like one long, continuous, mottled bone. This patient was not. He was very vascular. So during the operation, I thought to myself, if I'm going to do this very vascular decompression when he's neurologically intact, I decided not to do it just to save time and decrease morbidity. So the operative time was about 3 hours, and it was a very difficult operation because there was no anatomy. And here are the 4 points above and 4 points below the fracture, and the fracture's through here. And it's very difficult to see the normal anatomy. Here's the old end plate fracture at L4, and the whole spine was fused. So this fracture, if you had to make a story, probably happened like, who knows, 10 years ago or something. And the other interesting thing is this patient's 70, and he's a very unusual case for ankylosing spondylitis because usually they occur between the second and fourth decade of life, and then by the time people are 70, they're solidly fused. So this man didn't fit in any kind of rule book for ankylosing spondylitis. And maybe he doesn't have ankylosing spondylitis, although he does have fused sacroiliac joints.
What's the other disease? It's a German name, Strumpel.
We'll get into that.
Okay.
So
I thought that was just fused SI joints without the SI.
No, it's just a variant. It's just different people described it. So here's intraoperative films. I always get when I'm done every operation that I do, I get an X-ray afterwards. Do you have that policy, Doug? I get an image just to make sure the implants are normal and there's no retained objects or anything like that. I always get a final image, and here's the final images in the operating room. Now, unfortunately, it's hard to get a good image in the operating room. He's a big guy. His bones are osteopenic, like Adam said. So I was not 100% sure exactly where the implants were during the case, and unfortunately the O-arm was down, so I could not get an O-arm image. What do you know why it's down, Nate?
I have no idea what that
Okay, so I ordered a post. Huh?
When was this, last week?
2 Fridays ago. Yeah. Yeah. So here's the. Huh? So here's the post-op CTs, Adam, and what do you think here?
All right, so top left image, you can see the screws traversing through the pedicles, and
Here's the pedicles.
usually somewhere in the vertebral body.
Here's the spinal canal.
Yeah, and you can see there's no lucency surrounding the screws. And that looks fine. Now you go to the top right image, and you can see a fracture through the base of the pedicle there. The other side looks okay. Then you go down to the bottom left image, you can see that same fracture through the base of the pedicle. The right side, and that's the right side, so the left side looks okay. And then on those sagittal images, I don't really see.
Okay, well this is, so I can, what I look for here is I make sure the screws are right in the middle of the pedicle there and not into the foramen when I get these images, so you know what I'm looking at.
You have cortex underneath.
Yes, that's what I look for. And so my post-op, see how this right dead center in the middle of the pedicle, that's what I'm looking for on these images. And the other interesting thing is this is a better CAT scan than in the ER, and it's done at the same hospital, probably the same text, but the difference now is that he's calm because his fracture is fixed. And this man, the next day, said he felt better. He's like, I feel better, and despite having this big wound, because he's not moving at his level of the spinal cord, and his spine's fixed. So I thought that was incredible that he felt better the next day. And you can see the fracture here is that goes all the way across. And because he feels better, he can lay still in the CAT scanner.
And some of that worry, though, you've given us talks before on the thoracoplasty and the vertebroplasty, where those patients wake up from the conscious sedation that they get, and they feel, better right away, even though, you told us how some of that surgery was sort of, even the sham surgery, where in the controlled studies where the patients didn't get it, they felt better immediately waking up. So
yeah, it could be. It could be. That's a cynical point. And what about here?
All right, so it's a thoracic vertebral body level, and you can see there's fusion of the rib to the vertebral body. Another sign of ankylosing spondylitis. He's got a little bit of lung disease, probably atelectasis, and pleural effusion maybe on the left.
So this you got
of the costovertebral joint is another ankylosing of that joint.
I don't know if does anything else do that?
I don't think so.
Yeah.
The SI joints, as Doug was talking about, there are a lot of other
disease processes.
Spiro-negative spondyloarthropathies that can cause that, like Crohn's disease and irritable bowel disease, associated arthropathies. The SI joint is a commonplace.
So we didn't get a good view of the thorax with the CT scan pre-op, but post-op we did, and this basically confirms our diagnosis. And you can see this is where, when we take a deep breath, our ribs kind of go up and down like the hinge on a bucket. And so you can see how it won't budge if it's fused. So these people their ribs don't move. They breathe just from their diaphragm like a baby. So we'll go over. Any questions about that case, or any comments?
This is a man of 70 with ankylosing spondylitis. Did he have no symptoms before he
None.
was practice?
None.
He didn't have an abnormal posture? Or?
No.
Isn't that all?
Yes. See, this man does not. Like when you practice, a lot of things don't go through the rule book, so you can just ignore everything and think that the rule. But he doesn't fit our criteria that we've made. I didn't check him. But he's ankylosing spondylitis. But if I had to describe it, I'd say he's incompletely penetrated. So just like you remember in the pediatrics, you have all these disease processes where some of the children are incompletely penetrated. So that's what I think it is. Maybe I'm wrong, but that's my thoughts. But you got to treat him like ankylosing spondylitis. Diagnose it and then treat it. So these are all the different things you can call ankylosing spondylitis. Rheumatoid spondylitis. Maurice Strumpel was Maurice Strumpel disease. Strumpel was from Germany in 1897 who first described it. Pierre Marie in France 1898, and Bekhterev in Russia was the first known in 1893. So you can call it all these things: Bekhterev disease, Maurice Strumpel, pelvospondylitis ossificans, and ankylopoetica. And the basic problem is ankylosing spondylitis is this: the whole spine's fused, the spine to the pelvis is fused, SI joint, and you can get arthritis of your hips too. So this is the end problem. The radiographic features are squaring of the vertebra. So the vertebra usually have like curves to them, but in ankylosing spondylitis, they're very straight, like you made it with a straight edge, or you like drew it with a ruler. And the syndesmophytes bridge across the disc space. The spine looks like a piece of bamboo. You can see how it looks like a nice, clean piece of bamboo, unlike what Adam's saying, diffuse idiopathic skeletal hyperostosis looks like a big thing of wax, of flowing wax down. It doesn't look this regular. You can have erosions at the tendon insertions, so anthosopathy, and the SI joint fuses. So just epidemiology, who gets ankylosing spondylitis? It's usually men, 2 to 1. In North America, it's around 1 in 2 per 1,000. You never get it in the Aborigine populations. You never get it in the South American indigenous Indian population, and it's really high in Eskimos. So I don't know, it's a genetic predisposition. In the white population in the United States, it's 8%. African American is 4%. Scandinavian 18%. And ankylosing spondylitis, you see this Venn diagram, is part of a whole family of disease processes, like Adam said. So this is unspecified spondyloarthropathy, inflammatory bowel disease, psoriatic arthritis, reactive arthritis, Reiter syndromes, and they're all kind of cousins, sort of. And this is a great classic picture of somebody who has ankylosing spondylitis. As he grew older, he became more deformed. And you can stop this process by just physical therapy. Christina, what do you do for patients with physical therapy? Say a young man presented to you, 20 years old, normal guy. Well, I'd say an old guy like Doug presented to you, but he's pretty normal if you don't know him well. And what would you do for him? And he said he has ankylosing spondylitis.
I mean, I don't know that physical therapy is going to stop the disease process, but I would want to.
Wait a minute, I thought physical therapy can treat everything. No?
No. But I would.
Let me get another opinion. You're not saying what I want to say. Megan?
Oh, okay.
Can physical therapy help ankylosing spondylitis?
I don't know if it would really help it in the end, but I mean, I think you could talk to them and focus on posture, because if they start curving into their, getting into that forward posture, I would think that as it's starting to fuse, you're just going to fuse in that posture. So if you can keep
She's giving me hope. See, she's giving me hope.
I mean, I don't know.
Yeah.
I mean, if you can work on strengthening the postural muscles so that
Yeah.
you can focus on saying, you need to be upright as much as you can, and, getting into that kind of little bit of extension, maybe it will fuse a little bit more upright. I don't know, but
That's what the referring physician always wants. What he wants, he doesn't want to hear something else.
I think chiropractic manipulation would help.
Oh.
Well, when they reviewed the literature, physical therapy was one thing that had very strong correlation. I think it just teaches people to keep an upright military position, so when they fuse upright.
They probably fuse by the time they're not upright, though.
We'll go over that. It's an interesting point. So
You can
one.
certainly look at pain relief modalities as well. If there's not too much you can do, as far as you could say, maybe someone.
What's pain relief modality? What's
like
that?
TENS or stim or that sort of thing, just to provide sometimes you discharge a patient with a TENS unit at home because that can provide some pain
Just to
relief
break
for
a
them.
pain cycle.
Right. It's
like
not going
almost-
to change the disease process, but it could help them manage
It
the
helps.
symptoms.
I didn't think the majority of these people had pain. Here's a perfect
No, they have
example.
pain.
This guy was asymptomatic till 70.
This man did not fit the rule book, but usually people have pain.
I'm not so sure, because pain is when you have, usually arthritis pain is when you have a painful joint. These people don't have a joint.
Okay.
They don't bend.
You have a very good point, and what you're describing is chronic ankylosing spondylitis. We're gonna go over that.
Okay.
So who gets ankylosing spondylitis? More so in whites, 8%. African Americans less so, 4%. But a lot of people get the fused spines from reactive arthritis, psoriatic arthritis, and these people, a lot of them are HLA-B27. So if you have ankylosing spondylitis, almost everybody has positive HLA-B27 marker, 90%. But 8% of all white people in the United States are also HLA-B27, but they're usually not ankylosing spondylitis. So if you have HLA-B27, what?
They've got some other god-awful disease.
Who knows what? If you have HLA-B27, you're just off the street, there's a 2% chance you may have ankylosing spondylitis. So what are the other seronegative spondyloarthropathies? So this is like spondylo means spine, arthropathy means joint problem. Well, ankylosing spondylitis is one, reactive arthritis or Reiter's syndrome, psoriatic arthritis, this is a patient with psoriasis, enteropathic or inflammatory bowel disease, and undifferentiated is just people we don't know. So this is the research, how you can diagnose ankylosing spondylitis. This is the research tool that you use. It's called the Modified New York Criteria, 1984. And you need one of these criteria: low back pain for more than 3 months, which is better with exercise and worse with rest. So that's different from all the other problems we see in the back. That's usually worse when you work out or move around, better when you rest. So it's the opposite in ankylosing spondylitis. You're stiff in your spine, and your chest expansion is stiff too. Remember we talked about that because the ribs fused. And the radiograph, you have to have a radiographic finding. So you need one of these, and you need a radiographic finding of sacroiliitis. And we'll go over that. This is the X-ray. So what's fundamental to the diagnosis of ankylosing spondylitis is a fused SI joint. This is the research criteria that we have created as human beings. And this is the standard X-ray interpretation. We're going to go into this, Adam, but this is normal. This is a grade 2, which shows mild irregularity and sclerosis of the SI joint. This is a grade 3, which shows joint space narrowing of the SI joint and subchondral sclerosis. And this is a grade 4, which is totally fused SI joint by X-ray. Now here's a normal CAT scan. Adam, tell us why this is normal. This SI joint's normal.
It has the cortex is intact.
Mm-hmm.
The cortex is smooth,
Mm-hmm.
and there's a space, a joint space between the two bones,
Mm-hmm.
and it's train track sort of parallel lines,
Mm-hmm.
pretty much going through there.
Okay. And the bone opposite the joint is
not hypertrophied. It's
Yeah.
not abnormally sclerotic.
Mhm.
And there aren't any osteophytes really even at the anterior posterior margins.
Okay, so that's a normal SI joint. We're going to get into abnormal. So other features in the patient clinically that will make you think of ankylosing spondylitis is if you have a relatively young person, 45, less than 45, that has low back pain, a patient that presents with dactylitis, enthesitis, anterior uveitis, a family history, and twins, identical twins, it's a 63% correlation with ankylosing spondylitis, which is pretty high. Non-identical twins is like 20%. So for family history, it's about 15% chance. If someone's HLA-B27, if someone has sacroiliitis, these patients also can get proximal aortic disease from aortitis and conduction defects. They can have inflammatory bowel disease, and they can also get pulmonary fibrosis. So all these issues also increase the chances of the diagnosis. But clinically, the one thing you ask, my dog does this every morning when I wake her up in the morning, is she stretches and she's really stiff in the morning. So maybe she has ankylosing spondylitis, I don't know. But that's the key thing you ask people is morning stiffness. And their buttocks can hurt, and that's coming from the SI joint. They do well with steroids, so they may give you histories. I take Advil and I feel better. They have back pain at night, and they have a diurnal variation. I had to look that word up. Diurnal means it varies from day to night. So they're good during the day when they're at work and active, and then at night they have pain, and they have pain at rest. And again, 45 years old. So this is the question. This guy is half-eaten. He goes, "I'm done for. Save yourself." So the question is, like, the guys that are done for, the guys that are totally fused, that's it. They're done. What about the kids that get it? Like Dr. Spiro's like 20-year-old grandson. Like, that's the person that we want to help. And can we help those people? That's like the question. So there's two forms, like you said. There's, like Doug was saying, there's the people that are totally done, fused. Well, that's it. You're fused. There's nothing you can do for that person. But the people who are on their way to the disease process, maybe those people can be helped. So that's the big question. And the best way to diagnose it is probably like a radiologist think that they can diagnose and understand everything in the world. So it seems the best thing is a early MRI. So this is what do you think? What do you think of this MRI? Can you just explain
Yeah,
to people?
It's a T2 weighted study with fat suppression. So T2 weighted means water is bright. Fat suppression means that the water, normally on a T2 the fat would be bright, but because we suppress it, we make it dark.
There's
so
the fat.
therefore, anything that's white on that image is water.
This is a normal disc right here,
Yeah, so
right,
there's
Adam?
a normal disc at 5'1", but then you look on either side of the SI joints where those white arrows are, and that is showing you subcortical edema at the synovial margin of the sacroiliac joint on both sides of the joint, and the same on the other side.
And this is the joint right here.
Yeah, and it's narrowed and irregular there. It's not, there aren't smooth cortical margins on either side of the joint, suggestive of the ankylosing diffusion of the joint.
Okay, so just to one more time is on the
Well,
sternum.
STIR stands for inversion recovery, which is basically a T2 weighted fat suppressed image.
T2 weighted fat.
So bone marrow edema, which is bright. The periarticular
erosion.
region, so the white arrow lesions.
And
And then the subchondral fatty marrow infiltration, I don't think you can really see on T1, but we don't have a T1, so you can't see it
okay,
on there.
so these are just some interesting cases. This is a 28-year-old man with ankylosing spondylitis for 10 years, and he has what the American Journal of Radiology says. These are indistinct sacroiliac joints, but we're gonna go over. Same person now. The MRI scan shows subchondral fatty marrow changes. You see it right here. Do you agree with that, Adam?
Yeah, and again, when you have the fatty marrow change there, it's more of a chronicity. You get the edema in acute and continuous inflammation, but once that acute inflammation or even chronic inflammation goes away, and it's no longer inflamed as much, that's where the fatty marrow change happens. And this one, you can see the subcutaneous skin is bright, so that's telling us that this is not fat suppressed, and so those areas along the margin of the bone are bright, as opposed to the regular marrow, which is increased amount of fat in that marrow along the SI joint.
Okay, same patient now.
Same patient, so now you look at the subcutaneous skin and you can see that it's dark, or the subcutaneous fat, it's dark. So now we fat suppress. So those areas that were as bright on the previous study are not, and that tells you that it's fat, not edema. But there are some smaller areas of edema still, especially inferiorly and anteriorly.
Same patient now. So
Later, is he older now, or is it the same?
no, exactly the same patient. This is a coronal stir image, and the radiology report says this shows focal T2 prolongation of the SI joints.
And you can't see the SI joint too. That black, it should be a black line of cortex on either side of the ilium, and the sacrum has its own cortex, and the cortex is black, and you don't see that cortex anymore, indicative of the fusion.
Okay, this is a different man. This is a 43-year-old man, and this shows that he's
So the other
fused.
image we were looking at was kind of coronal, sort of as he was standing up, or along the joint space line. This one is more of an axial image now, with his belly button towards the ceiling and his back towards the floor. And so we're looking at the anterior margin of the sacroiliac joint. And if you look at the normal bone, right where your arrow is, just to the left, there's a normal black cortex. And you don't see that at all. The whole area there is black. And this is a T1 weighted image. You can look in the bowel and see that the bowel is black, and all those other and vessels are black. So the only thing that's bright on a T1 weighted image is fat or blood. But in this case, fat, so that area is all black, and so that is either edema or bone sclerosis.
So this is more of a chronic ankylosing spondylitis. So if you get an MRI of these young people with sacroiliac joint ileitis, you can maybe make a diagnosis of ankylosing spondylitis. But there are other things this is the differential diagnosis of sacroiliitis, and it's huge. Like Adam was saying, inflammatory bowel disease, Crohn's, ulcerative colitis, hyperparathyroidism. I don't even know what a lot of these are. Psoriatic arthritis, reactive arthritis. Does anybody know what Behçet disease is? I don't even know what that is.
That's where you get the things in the brain, I thought. It's like multi-system.
I used to know, but I forgot.
Okay. Rheumatoid arthritis. Neoplasm, infections. Tuberculosis, of course, sepsis, SI. I've seen several SI joint infections, and they didn't have this traumatic arthritis too. We had a patient came through the other day here at Chesapeake who had a traumatic old pelvic fracture, had traumatic SI joint arthritis, and they thought it was an infection, and it wasn't. It was just trauma. So what can you do for these people? Well, the first mainstay of medical treatment is non-steroidal anti-inflammatory drugs, and here's a list. What's Doug, what's your favorite non-steroidal? Do you have a favorite?
Ibuprofen.
Really? Ibuprofen? Why do you pick ibuprofen? So ibuprofen's Motrin, Vicoprofen.
This works for me. And now
Personal
it shoots
experience?
up my stomach, so I can take ibuprofen.
Okay, it's interesting. I don't like ibuprofen because I feel it's good.
And I think aspirin is a good first-line drug, too.
Aspirin?
I think you want to give something to people that it's cheap, you can get it over the counter, it's well-known.
Anybody else have any favorites? So everybody here is ibuprofen is their favorite? I don't like ibuprofen because it's too, for my purposes, it's too short acting. People have to take it 3 times a day for chronic disease processes, and they always forget. I can never take a 3 times a day medicine. I can't remember. So that's why I like once a day medicines, because it's easier to be compliant. I usually pick meloxicam, and it's also generic. You can buy it at Walmart for $12 for a 3-month supply. But I don't think it matters what you do.
I think there are 28 on the market the last time I checked, and I tell people it's like ice cream. Some people like vanilla, some people like, it's all the same. No, basically, some of the side effects are what different. The other thing is AS, does it affect other joints, or was this just designed by a spine surgeon?
It does fit. We'll go over that.
Hip or knees, or?
It'll be a segue. It's a good segue. Next thing. But the other thing, treatments for these people is bisphosphonates. Now, the people who fail non-steroidals, when I say fail, it's persistent stiffness and pain. There are other treatments you can try for people who have peripheral disease, like Doug was saying, hip, knee, ankle involvement, enthesopathies. They respond to sulfasalazine well, but usually these other drugs, these disease-modified anti-rheumatic drugs, they don't work well in ankylosing spondylitis in general. Cyclosporin, methotrexate, corticosteroids. But the one that does work well is tumor necrosis factor blockers. So they've done studies where they biopsied the SI joint, and they found in the SI joint a very high level of TNF, tumor necrosis factor. So all these chemotherapies are infusions of anti-tumor necrosis factor, biologic agents, and it stops the disease process dramatically. So this helps if you fail non-steroidal. And this is obviously not I don't know anything about this. I'm a surgeon, but this is how rheumatologists treat ankylosing spondylitis. And if you diagnose it early with an MRI, you can do that. So this is but sometimes it's too late. Like for this woman, it's way too late to ride the chopper. So this is what you want to avoid. And the other problems you can have fused hips, and you can have terrible hip arthritis as well, and flexion contractures.
If you go back one image, please, there's another classic radiologic finding on the frontal radiograph on the right image. If you look at the spinous processes, how it's called the dagger sign, and that is because they are so fused together it looks like a dagger. And then the other one is a tram track.
Hold on, I want to stop. I don't want you to go on. Let me stop here. This is what you're talking about, right?
Yes.
So for me, is the posterior spinous processes and the interspinous ligament.
Yes.
And in the old cases, in the chronic people are totally fused. That thing's like it's a piece of bone all the way across. It's incredible. This guy, last case, did not have that.
Right.
So he was an active in the active disease process. And what's the other one, Adam?
Well, and then the other one is the same on the AP. We call it the tram track sign. You think of not a monorail but a triple rail. So along the facets, along the spinous processes, and along the facets, because they're all solidly fused, you'll have 3 parallel vertical lines on the AP of the spine that go along with ankylosing spondylitis.
What do you call it? Tram track?
Tram track. Yeah.
Okay. Okay, so there are other things called the Schober's test. I put this in because Eric asked me what it is, and it's just a generic way of seeing how stiff someone's back is. You put a mark 10 centimeters above and 5 centimeters below his pelvis and have them bend forwards and back. And normally the skin should move. It should get longer because you're flexible. But if people with ankylosing spondylitis, they don't move because they're fused. So it's just a way to see how stiff someone is clinically. And their ribs don't expand. So if you put a
So they're moving at their hips or knees rather than
right, and see if their chest expands, and if it doesn't, more likely ankylosing spondylitis, and they're breathing through their diaphragm. And the other thing to measure for these people is from the wall to their occiput to see how bent forward they are. And that gives you like just a way to measure it. The other thing is spondylodiscitis. Has anyone here seen spondylodiscitis, ankylosing spondylitis? It's a very interesting part of the disease is where they get a chronic sort of non-union of the spine. So they get like a stress fracture sort of through their spine, and they keep healing it, fracturing it, healing it, fracturing it, healing it, fracturing it, and it's like a Charcot joint of the spine. It's kind of amazing. Usually this does not need surgery. I've probably seen 3 cases in my career so far. And here's the little closer. You can see it looks like a non-union of a fracture, and it's not an infection. It's just a non-union, and it heals. Heals fractures, heals fractures, heals fractures. And there's other neck injuries. You can have a subtle cervical thoracic junction injury, or you can have a bad cervical thoracic junction injury, and you need a CAT scan to diagnose it. So any neck pain and ankylosing spondylitis needs a CAT scan. Any other comments for that, Adam? Or so anybody want to make any comments or questions so far about ankylosing spondylitis? Okay, we got one more case. This is Doug will be the treating physician. It's a 59-year-old man who has 2 months of back pain. And he says it's mid-thoracic back pain, and he presents to your office. Here are the x-rays. What do you think, Doug?
It looks like he has normal disc space, normal vertebral body height.
Mm-hmm.
He does look like he has, tough to see on the lateral, the top. I can't really see where, it does look like he has fairly significant kyphosis.
Mm-hmm. Is that abnormal? People get kyphosis.
I'm not seeing it very well, but he does look like he has a bridging bone across his vertebral bodies.
Okay, so what do you want to do with him? Neuro intact on exam. Ibuprofen? That's your favorite drug.
I'd probably, if this is the first time being seen, I'd probably treat him with anti-inflammatories.
Okay, so I think that's very reasonable. He has no injury. Here's his lumbar x-ray. He's had bilateral total hips. So he didn't get better, and he was sent for this. The steps were, first was the MRI, and then I ordered the CAT scan. So what do you think here, the MRI, Adam?
That vertebral, on the bottom left image, there's the black, right there, the black vertebral body. So that is a T1 weighted image, because we look at the CSF, and the CSF you can see is black. And so black on a T1 weighted image is typically going to be water in the marrow, so that vertebral body there is very edematous.
Mm-hmm.
You look at the bottom right, or the middle right image, and that's a T2. Again, the CSF is bright, and there's edema permeating throughout that vertebral body as well as within the abutting end plates.
But it's more than just this vertebral body. Don't you think it's that one and that one?
And then there's the dark signal.
Have you ever seen edema? Excuse me, Adam, but have you ever seen edema go across the disc space like that?
Well, I mean, yes, because you get the modic changes when there is disc disease isolated at a level. You're gonna, when there's an arthropathic level, you typically get it above and below the space. So I think, this is the disease centered at that one, but the disc space above and the disc space below, there is disease there, and it's causing this inflammation in the corresponding.
But usually it's just about the disc space. See, this is a fracture, and because this thing's like a femur now, it just goes across the disc spaces, because the disc space is not even there anymore. I think it's just like, I think in really end stage, there's no disc space. It's all one big long bone. So this diagnosis initially in radiology was degenerative disc disease with modic changes. But obviously we know it's not. But you can see how you can be fooled. Okay. So, and what do you think of the CAT scan?
The CAT scan shows the fractured vertebral body and the disc space. And
Okay.
It does look like it does go into the posterior elements.
Okay, so this, and here's what about the coronals, Adam?
He's got a pinch of his spinal cord also on that MR.
Right here. What's this stuff right here, Doug? You said, so it's pinched, it's in the front
Yep.
from the fracture, and there's a fracture in the back, and why is there stuff here? What's that? Can you guess?
Fractured as posterior elements as lamina or something is splintered into the canal or blood.
Yeah, or blood, or
Yeah.
I think it's callus. So he's kind of like maybe a spondylodiscitis sort of. He's sort of becoming a spondylodiscitis, and he's laying down callus.
The left image, though, makes me think the spinal cord is not pinched.
Yeah, that looks good
it
there.
could be that it gets if he bends over to pick something up or leans back, or because it's unstable and there can be motion. But the spinal cord on that one image there is not.
He's been like that for 2 months, though.
Yeah.
So what about the coronal cuts?
So then you can see the fracture both through the patient's left, on the image it's the right of the above vertebral body, and then going down into the disc space, through the disc space.
What about here, Adam?
And that one looks a lot, especially the right image, you can see the fracture and the fluid within the joint and extending into the posterior elements and the malalignment of that posterior facet.
Mm-hmm.
Same
There's
thing
another
there,
view.
the edema.
So what do you think, Doug? You think this is an emergency? What are your thoughts?
I think it's urgent. I don't think it's an emergency. If you say he's had it for 2 months,
2 months.
yeah, it's not an emergency, but I think it's urgent. Within a week, within a couple of days.
What about putting, let's say for whatever reason you can't get him in to operate, would you put one of those plastic chest braces on to?
This is a big dude. He's a big guy too.
Yeah.
What do you think, Doug? TLSO, like you're talking like a molded thoracolumbar sacral
I think
orthosis,
that-
like a body
that
jacket.
might even do him more harm, I would think. Unless you really had it custom made, almost like a Minerva or something like that. I might Minervarize him, but I'd probably just admit him to the hospital and do.
They don't work well. Those braces work well in young, thin women that you can really mold to the person's body to hold it. They don't work well in big people, and especially older people. Kids tolerate anything. You can put the child in a brace for years, but adults, they just don't deal with it. They just don't. They don't want to do. They won't put it on. It hurts. It's uncomfortable. They can't breathe. It's just not tolerated. So, but this he was a little bit sort of like spondylodiscitis. He's had it for 2 months. So I can't act like it's an emergency. It really isn't an emergency.
Right.
I have to be honest with myself too. But it's something that, and he's obviously miserable and needs to be treated.
Right.
So I put it on, like you said, I just put it on the next week on the schedule. And intraop, see how this is what Adam was saying. See how this thing is one solid piece of bone, up and down, the Adam Morgan dagger, and you can find the crack. And he was almost completely fused. Totally different case from the last week's. The last case was bled like crazy. This guy didn't bleed at all. Just the soft tissue just peeled totally off like a child's periosteum. So this was more of a chronic ankylosing spondylitis that totally fractured. Very different case. And you can see the crack all the way through the whole spine. And it just put 4 points above and below the implants. And this man was the same. He had dramatic improvement, total pain relief. But then it was a very odd case. He came back 6 weeks later, and from the point from 6 weeks to 12 weeks, he had a lot of pain. And I don't know what it was, but then it went away. So
Was that what Adam was talking about before? It was the
placebo effect.
You're great. You're great, aren't you?
No, that is true actually. They studied in orthopedics that when surgeons did their own research, the results were always much, much better than if an independent person asked the patient how they're doing. Because the patient's embarrassed. They don't want to tell the surgeon that it's a total failure. And they always say, have you noticed that? They always, and then when the patients call, the staff, they're not as nice as they are to the doctor. They're always nice to the doctor. So there's truth to that. Okay, any questions about anything?
I did look it up. There is research to say that exercise is important, although it doesn't change the disease process. So, in the earlier stages.
Oh, yeah.
Not about anyone then, right?
Well, yeah, and a lot of the things too, like as far as making them breathe deeper, rib expansion, flexibility, working on the soft tissues, even, because your muscles are going to get shorter and tighter too if you don't try to stretch them and exercise them and work on posture. So.
Physical therapy was definitely studied, and it helps.
Studied by a physical therapist.
Not necessarily.
Well, people
I think it's like send them out to a nightclub and let them have a good time. It's just as good as physical therapy. You know, the girl dances
Only
on
if
your
they're
back.
dancing.
It dance on your back. You know,
a girl
the next-
dancing on your
next
back.
day you have a
What kind of
headache.
clubs do you go to?
You feel better, you know?
He's like at that ortho meeting in Vegas.
Well, you know,
That's not a club.
It's like, you know, I believe in physical therapy, don't get me wrong, but a lot of times people say, well, you know, it feels good when when they're rubbing my, muscles or something, but the next day I'm back to where I am again, you know, it's like, okay. Well,
Yeah, but it breaks a pain cycle. Though.
Right.
That's how it works.
Yeah.
Because you have that pain cycle, and if you can
Right,
break that a little bit.
okay, but let's think, is that any different from like going to see a masseuse or, getting spending a day at the spa also? I mean, I think that there are a lot of things that make people feel better.
Yeah, but then you also have to teach the patient what they need to do to keep it better, because insurance isn't going to continue to pay for us if we're not demonstrating a change, whether it's they can now demonstrate independence with their exercise or whatever else. We're very scrutinized in what we do.
You're both right.
Because manual in and of itself is a way to help people feel better so that they can exercise, so they can get stronger, so they can support their.
How about, do you believe in
joints.
personal trainers?
I think there are good ones.
Yeah.
Yeah.
I tell you, I've been going to physical therapy now for 8 years.
Yeah.
And there's so many times that I'm there and I'm like, why is that kid here or that person here?
Yeah.
Because can't they just do this on their own? And the answer from the therapist is, well, of course they can, but they won't.
Yeah. Sure.
And so it's not just saying, look, I've treated you for a month, get a gym membership and do it. They need the person to pressure them into do it, but then also it's telling
Otherwise,
them how
they
to
come
do it
back
right.
and complain to the doctor that they still
Right.
have pain.
But it's also they have to do it right. If they don't know how to exercise right and they just go into the gym and say, well, look at that guy bench pressing 200 pounds, I want to do that, and it's doing the right exercise and the pressure to keep doing it.
So it's cheerleading and education.
Yeah.
And really, when you're talking posture, a lot of people have a really hard time. If you're working on scapular strengthening, they have a really hard time understanding that where their scapulas are in space, and that cueing of hands-on and asking them to, you need to pull right through here, and stopping them when they start compensating, because a lot of people say, if you do 20, I want you to do 20. At 10, they might start really compensating, and you have to have them stop. But most people on their own won't stop. They'll kind of keep going through, and then you're now injuring other muscles if you're not really focused on stabilizing the right muscles.
Don't be cynical, Doug.
The discharge plan.
Life is
includes going to
beautiful.
the
I'm not cynical
And
at all.
everybody
I'm
has-
not cynical.
Everybody's
I'm not
right.
cynical.
He's a realist.
I'm a
Huh?
realist. Thank you. I mean, I like that picture of the man that you showed, 47, 50. I mean, it was terrible, I'd like to see one, where you, now where you can show an intervention. Where here's the man, here's when we treat
Right.
him,
Well, you're right, but
I'd like you to make up the slide for next week, Spiro, show some guy after physical therapy.
this one right here, right?
After surgery.
This one-
I feel great.
So if we couldn't give this man in 1947 tumor necrosis factor,
Look at him.
yeah, tumor necrosis factor, and physical therapy and non-steroidal inflammatory drugs for years and years and years, he will not become this man 28 years later.
Well, I wonder if your other guy, because was he a farmer, the one that fell off a tractor?
And that was his physical thing. He had to get up and do the
That's
work.
right.
Exactly.
By himself.
I mean,
cutting the grass.
the cows were mooing, the field needed to be done.
I mean, there's something we talked about in rheumatoid, where you see it in women, where it's the classic textbook case of rheumatoid, and then you see it in a man of the same age, and there isn't the periarticular osteopenia, and there are still the erosions, there's still the arthritis, and it's because he worked through it. He had the pain where, as the person that wasn't on the farm, that didn't have the cows mooing, that he absolutely had to go do it because it's his responsibility, it's what he does. The person that had the option not to do it, that's where they get the contractures and the osteopenia.
I'm not going there.
I skirted it a little.
Not
Okay, thank you, everybody.